Huh?
Good evening, everyone. This is Dr. Satya Yadav. On behalf of Society for Pediatric Cell Therapy and Transplant, I invite all of you to this second webinar. It is a monthly webinar series which we have to cover bone marrow transplant and cell therapy for trainees and young faculty. So today we have an excellent session lined up on HLA, and we have a brilliant speaker with us, Professor Vikram. And so I will hand over mic to Sunil Bhat to update you on activities of SPECT, and then we take on to progress to the webinar. Thank you. Sunil?
Hi, good evening, and thank you, Dr. Yadav, for the introduction, and welcome all for this second webinar, which is a monthly event, as Dr. Yadav just mentioned. Just to give you a little bit of update from the last meeting, we had the inaugural academic meeting of SPECT last month. That was on 30th of July. And, we're quite surprised, actually, in the first inaugural meeting itself, we had more than 190 logins from the attendees, and there were faculty as well. Who had participated, and there was a good discussion at the end. And in fact, we couldn't take all the questions. We really had to kind of respond to some of the questions offline. Now, SPECT, as you know, is growing in membership. We have reached almost 120 members. And just to kind of again brief about the SPECT activities, it's Society for Pediatric Cell Therapy and Transplant, and focus of this society is going to be pediatric stem cell transplantation and cell therapy, going forward. So there are a few activities lined up, including this academic activity, and there'll be a few more things coming up eventually. I request ones who want to participate and be the member to write to us, and we'll send you the details for registration. And with that little, brief on the activities of the SPECT, we'll go ahead with the scientific session. It's indeed a privilege for me to introduce the chairperson for this, for this academic event today. It is going to be Dr. Ganesh Jaishetwar. We all know him. He heads the Hematology and Stem Cell Transplant Program at the prestigious Yashoda Hospitals from Hyderabad. So he's going to be moderating this session. And Dr. Ganesh, over to you. And if you could introduce the speaker and take the session forward. Thank you very much for joining as well.
Thank you, Dr. Sunil. Good evening, everyone. It's indeed an honor and privilege to chair a session which is going to be delivered by none other than Professor Vikram Mathhew, sir. So I'm sure this August audience, even though virtual, doesn't need Dr. Professor Vikram Mathhew, sir's introduction, but I'll just, share a few of, his introduction from a student like me, student's perspective. So directly or indirectly, Professor Vikram sir has been mentor to most of us active in the field of hematology, stem cell transplant in India. Currently, Professor Vikram Mathhew sir is the director, prestigious Christian Medical College, Vellore. Beside being super busy with such a 2,600 bedded CMC Vellore, he is at the forefront of clinical work and bringing the innovations in the clinical medicine from the field of hematology bone marrow transplant to our patients in India. The sir has more than 150 peer-reviewed, high-impact journal publications with more than 9,000 citations, and he is a pioneer in the field with many breakthrough, innovations brought to clinical practice for our patients. He is the father of the arsenic trioxide in India for APML patients. He is also all of us now know him. Previously we used to use the Locatelli's classification for thalassemia, but now, after his pioneering work, most of us are following his, revised thalassemia risk stratification for transplant. So there is so much to talk about Professor Vikram Mathhew, sir, but I will hand over to Professor Vikram Mathhew, and all of us are eager to listen the essential topic of HLA and its relevance in the field of hematopoietic stem cell transplant. Over to you, Vikram.
Thank you, Dr. Ganesh. Very generous introduction. Thank you so much. Appreciate it. If I can fulfill all that. But can you see my slides and can you hear me clearly?
Yes, sir.
Yeah, we can see. If you can make it full screen, that would be great.
Is it full screen now?
Yes, sir.
Yeah.
Okay. Okay. So thank you for inviting me to this body, and I'm going to be talking a little bit about HLA over the next 30 to 35 minutes. So when Satyendra called me and said, "You want to give me this talk?" the first thing that came to me was the book that I read long, long ago as a student. I'm not sure if any of you all have had this book or read it. It's called HLA Beyond Tears. This is gives you a sense of what people feel when they think about HLA. Sometimes it can be kind of overwhelming, to try and understand it. But I think two disclaimers that I must make. I said, one, I told Satyendra, I said, you must really hate me to give me a topic like this. And he said, no. It would be good if you could do this. So HLA is one of those very specialized areas. Actually, none of us can truly just dabble in HLA. So all of us have to rely on labs and people who are experts at it. So I will walk you through a broad overview of HLA. And I think it's important right in the beginning to say that HLA is one of those things, there's a lot of opinions. Not many of them are really substantiated. Everybody has a perspective, and you can literally find a publication to support any particular association that you want. There is an incredible amount of complexity. And in addition to that, what has changed over the time is the use of post-transplant cyclophosphamide, which has kind of changed the field upside down. But keeping all that aside, I'm going to try and give a broad overview. I'm going to assume that there's a fair amount of students in this audience. So some of it is going to be fairly basic. So please bear with me on that. For the rest, I know is a fairly advanced audience over here. In addition to that, there is so much data. I'm just going to I've tried to kind of just take some key large data sets just to illustrate certain points. There will always be some data that counters any particular data set that you show. So keep those caveats in mind as I move forward. Now, the principles of an allogeneic stem cell transplant, I don't think I need to illustrate to this audience, but basically you have a donor and a recipient, and you have to basically condition the recipient, and there are different strategies to do that, and you can take stem cells from different sources. And today we have various types of donors. A related matched sibling donor to a mismatched related donor, mismatched or matched unrelated or mismatched unrelated donor, to what is now fairly common, a haploidentical transplant. And for the most part, good things happen after a transplant, but many of the bad things like rejection, GVHD, etc., are often fundamentally related largely to the HLA, but not entirely completely. And therefore, there are many aspects of this, which is a complex interplay of many factors. It's not possible to address all the interplay, but I will touch on some of the key factors. So let's start with HLA. The human leukocyte antigen is basically a region on HLA chromosome 6p21, which actually is the region where the genome for HLA class 1, class 2, and class 3 exists. And there's a concept called linkage disequilibrium that is basically the striking tendency of genetic variants to be found together in the population when these variants are located reasonably close together in the genome. And therefore, they tend to be inherited en bloc. So while we have two such 6p chromosomes, this entire block is inherited as one block, and on the other chrome is inherited as another block. When there is a father and a mother and there's normal meiosis, 50% of this goes to one part of the contribution to the formation of a progeny. The other part comes from the other partner. So they code for glycoprotein molecules expressed on the cell surface. And the class 1, as we all know, the common ones are ABC. And the class 2, the common ones are DR, DQ, and DP. But there are sub-isoforms of them. And the class 3, which we don't usually talk about, is various cytokines and TNF, etc. Now, it's important to recognize that the first allo stem cell transplant was done about 1956 by E. Donald Thomas, while the first HLA was actually described only in 1958. And in fact, only in 1960 was the concept of a hematopoietic stem cell actually described by Till and Maclow in their really landmark paper. So it's interesting to note that allogeneic stem cell transplant precedes even the understanding of HLA, and that had significantly negative impact on the early transplant outcomes with high instance of graft rejection, early mortality, GVHD, etc., leading to death. As our understanding improved, the outcomes gradually improved, and a significant part of that was improvement in the ways that we could do HLA from low resolution typing to high resolution typing, and of course, subsequent additional advantages in supportive care and conditioning regimens. The very basics of HLA inheritance and chances of a match. So as I said, because of linkage disequilibrium, the entire HLA complex is inherited as one complex. For example, in this mother, one complex on one chromosome is depicted as A, and the other complex on the other chromosome on the pair is depicted as B, and similarly, father is C and D. And there is conventional Mendelian inheritance, it's autosomal, and it is what we call co-dominant expression. Unlike sometimes when you have gene expression, only one gene expresses, the other is silent. So, for example, in an XX in a woman, we talk of lionization. One X chromosome is silenced, and sometimes when you have two genes, only one is actually expressed, and often that is adequate. But here, both sets of genes in the pair are expressed. So the inheritance, conventional Mendelian inheritance, all of you all are familiar with that. So, for example, if this haplotype of the mother is given to the progeny, the pair that comes from the father could be either C or D. So it could be AC or it could be AD, and similarly vice versa if the B haplotype. And as a result of that, the chances that for every single sibling that is born to a parent, the chance that they'll be identical is 25%. The chance that there'll be 50% match is haplomatch, and the chance that there'll be a complete mismatch is 25%. So what is the chance of finding a HLA match if you have 1 versus 10 siblings? So technically, on a mathematical model, you can calculate it. We don't really do this. I think the only important things to remember is that no matter how many siblings you have, there is never a stage where you can say 100% there is a HLA identical sibling. And the second thing is, for every single sibling that you look at, the probability of match is always only 25%. But it's like a dice having 4 sides. Every time you throw it with 4 sides, a 4-sided dice, every time you throw it, there's only a 1 in 4 chance that a particular number will come up. But if you're given multiple chances to throw out, your probabilities of the same number that you want coming up increases. And that's illustrated by a formula here. So if you have 1 sibling, theoretically, your chance of having a HLA match sibling with the next child is 25%. While if you have 10 siblings, the chances that at least one of them is HLA match is almost 94%. Some caveats have to be remembered, especially when we talk about Mendelian inheritance. Now, conventionally, we said if you have this usual haplotype inheritance, you could have 1 in 4 who is HLA identical, 2 out of 4 who is haploidentical, and 1 that's a complete mismatch. But occasionally, what can happen is what is illustrated in sibling 6. Here, what can happen is, if you look at the A29 haplotype in the mother or the A26 haplotype, the A29 goes with the B44 and the DR7. The A26 haplotype goes with the B38 and the DR4. But occasionally, what can happen is, when there is meiosis, the crossover can happen in such a way the A26 haplotype has crossed over to the A29, and the A29 has crossed over to the A26 in the process of meiosis. So now the A26 haplotype is actually associated with B44 and DR7. So you could have this unusual situation when you have the entire family haplotype. Only if you have the entire family haplotype mapped can you actually identify this. You can have recombinations of 1 or more of the HLA antigens. and this recombinant. So when you have only the siblings and you find this aberration, don't immediately jump and start questioning parenthood and all that. Please remember that occasionally these recombinations can happen where suddenly you just see one antigen mismatch. So in that situation, you should do the father-mother to understand very clearly what the haplotype is and if there has been a recombinant. These are fairly rare events. It's not like you see this every day, but every now and then this can happen, and it's important to kind of remember that. Now, when you talk about HLA coming at a molecular level, the HLA class 1 molecule consists of a structure which has an alpha-1, alpha-2, and an alpha-3 chain. And at the base is a beta-2 microglobin, which comes actually from another locus, which forms the HLA class 1 molecule on the surface. The HLA class 2 has an alpha-1, alpha-2, and a beta-1 and a beta-2, beta chain and alpha chain, and the alpha and the beta have the 1 and 2 respectively. Now, within these, there are regions which are the hypervariable regions where there is a lot of polymorphism. And this is what gives the sensitivity and specificity of the HLA class and distinguishes one individual from another. And this is something that is inherited. And because of linkage disequilibrium, you're likely to see patterns within similar populations. So, for example, the Japanese, the Chinese, some of our South Asians are very diverse, but you can see patterns within large populations which are fairly similar. That kind of linkage disequilibrium can be seen. And what is essentially when we do sequencing is we sequence these hypervariable regions are what we sequence for to identify differences. And please remember, this is a moving field. There's constantly new and new epitopes being described. This was taken some time back. The class 1, there are almost 15,586, class 2, 5,913. HLA class 1 molecules and HLA class 2, 5,913. So totally almost 21,499 variants can be identified by various polymorphisms. Now, when we look at HLA classification, it's important to understand the resolution of the classification. And I'll talk a little bit about that. At low level, we just identify the gene and the broad allele. At the medium level, we are able to take it to the antigen level. And a high level resolution, you can get additional details. And the way to look at it is shown over here. The HLA-A, for example, just gives the broad gene name. The first number that you say, which is usually after a separator, 02, refers to the allele group, the broad allele group. And the next 2 digits usually will be the HLA-specific protein. That is the particular epitope or the particular antigen. And so people have often tried to say, is allele difference more important than antigen difference? And there's now broadly a recognition that even an antigen difference is as relevant as an allele difference. This is broadly what we actually look for, but additional details are after the next hyphen. What is usually shown is a synonymous DNA substitution. What do you mean by a synonymous DNA substitution? At the DNA, all of us are aware, it's a triplet code that signals a particular amino acid. And occasionally, you can have a change in the nucleotide, but does not translate to a change in the amino acid. So the same triplet, a difference, even a single nucleotide change will have the same amino acid that is taken up. So you won't actually have a difference at the peptide level or at the amino acid level that is taken up, but you can have a difference at the nucleotide level. And this just illustrates that. 02, the next one that comes after that is usually a difference in the non-coding region. While these may not cause, the last two may not cause a significant change in the antigen structure, there could be subtle changes in the protein folding, etc., that can cause differences in the way that the antigens are presented. And this knowledge, as it increases, more and more of these associations will evolve. So HLA typing, we started with very serology. I think, this discussion for the most part is a pure theoretical exercise because almost all of us today get high resolution typing. But historically, it used to be low resolution typing, which is just serology based. I've been in an era where we used to do it when I started transplant. It's a very laborious process, especially class 2, where you had to separate these B cells to a very exhaustive procedure and then look for antibodies. on these particular plates and then look for cell lysis. Those things are things that we don't do anymore. At an intermediate level, what we are using is basically single cell, polymorphisms that we have sequence-specific primers, like a PCR reaction, multiple PCR reactions. And at high resolution, basically, we are using a next generation platform, which gives you very high depth of resolution and can give you all the details that I showed you in the earlier slide in terms of antigen, allele, and further subdivision with regards to the details of the synonymous mutations that can happen and non-coding region sequences that can happen. So conventionally, a HLA typing report, just to illustrate, will look like this. Usually it will have a 3, and usually these numbers will have a report at the back of it, which shows you whether they are similar or they're different or whether they're related to certain broad overgroups. And conventionally, we do A, B, C, DRP1, and DQ and DPP1. So that's usually, if you take ABC, DRB1 and DQ, it's 5 alleles. And if you take DPP1, it's 6 alleles. And there are a pair of them, so it becomes 12. But there are 5 others which we routinely don't do. That's the DRB3, DRB4, DRB5. The DQAB1 there is, and DPAB as well is there, which are not conventionally done. But theoretically, going ahead, these are the most important ones which have an impact based on large studies. So it's important to remember when we talk about 8x8, we're talking about matching restricted to A, B, C, and DRB1. That's 4 alleles, and pair makes it 8. When we talk about 10x10, we're talking about A, B, C, DRB1, and DQ. And we talk about 12x12, we're talking about A, B, C, DRB1, DQ, and DPB1. And the pair of them, because they're 6, it will become 12. And so we are looking at complete matches. In addition to this, there are a lot of additional other subtleties. Example. So for example, in DPP1, it's a well-recognized phenomena where you can have different antigens, but they are not recognized well by the T cells. They are called permissive mismatches. So that actually, while we talk a lot about it in the context of DPP1, can also happen with the other HLA. So just because there's a difference doesn't necessarily mean that there is definitely an antigen recognition difference. Now, this kind of information only your HLA lab or your specialist can give you, and this can vary from population. So for example, in the Japanese population, what is permissive may not be permissive in a Caucasian population, or what is commonly permissive in a Japanese population may not be seen so much in a Caucasian population. You may see a different type of permissive matches. So these kind of variations are there, and that should be kind of remembered. So the role of HLA is in the recognition of self and non-self. Recognition of self, you can imagine the context of GVHD. It can react if it's not self. And recognition of non-self is in the direction of rejecting a graft. The immune response to antigenic stimuli, coordination of cellular and humoral immunity, plays a key role in antigen presentation, immunological recognition of differences in HLA, first step in rejection. In the solid organ transplant, it has very significant impact on transplant rejection. And remember that HLA is also expressed on endothelial cells, like the ABO group mismatches. And this in solid organ transplant have different implications on the pattern and type of rejection that can happen. It has implications on transfusion therapy, as all of you all are aware, when we use HLA matched or at least compatible or cross-matched platelets. There are various disease associations, for example, HLA-B27 and any of the autoimmune disorders, which we will not talk about it too much. The broad organization is class 1 is expressed on all nucleated cells. Class 2 is expressed on immunocompetent cells and antigen-presenting cells. And the antigen, and also on B cells, and immunoactivated T cells also express class 2. It's also important to remember the antigen-presenting cells, if you can see, are enriched in the skin, gut, and liver. So what does that strike you when you see this particular pattern? These are particularly the regions where the GVHD usually happens. So it kind of tells you that these are regions where there are first entry of organisms into an organism. Break of skin, gut, or liver is often high intensity of antigen-presenting cells, because those are regions of the body which have a high risk of exposure to external agents, toxins, and infective agents. And therefore, those are highly areas where there's a high chance that they pick up agents that can be then presented to the immune system and cause rejection. And for the same reason, those antigen-presenting cells can pick up your own antigens and present them to the incoming T cells, and also are the same reasons why you have high incidence of GvHD in these particular regions. The class 3 we don't talk about much, but includes complement and certain other enzymes and human necrosis factor. The complement is important in the context of antibodies, especially C1q and recognition of complement by the antibodies, which have a greater incidence of graft rejection. So a very simple way to remember signaling is the T cells. The CD8 positive T cells are usually recognized by MHC class 1 and CD4 to class 2. So the product of CD8 and the MHC is always 8. You can remember that concept. So CD4 positive cells usually recognize antigens present in the context of MHC class 1, while CD8 recognizes in the context of CD8 recognizes class 1. So now you can imagine CD class 1, if you remember, is expressed by all nucleated cells, or all nucleated cells, and therefore these MHC class will unlikely to be presenting their own or autoantigens, and CD8 are cytotoxic T cells. So CD8 will only recognize when MHC, which is in the usual context, would be some foreign protein that is recognized. So MHC class 1 is very important in distinction of self, and that's a complicated process. But beyond, and CD4 on the other hand, when it is stimulated, is not sufficient usually by itself, so none of this is absolute. Usually involves recruitment of other cytokines, etc., to then activate the immune system, both the adaptive and the innate immune system. Now, the T cells require, in addition to this initial cross-presentation of antigens by the MHC to the respective T cells, they need other co-stimulatory molecules, as all of you all are aware, and they can be both stimulatory and negative. And of course, with the checkpoint inhibitors, all of us are aware of the negative regulatory pathway of CTLA4 and PD1, but the positive regulatory pathway is CD28. And this is important because sirolimus is something that targets this particular pathway. And the third signal is cytokine. So ideally, all this has to come together to elicit an immune response. And often these are kind of auto feedbacks that kind of feed on itself and drive the immune response. But there are also checkpoints that keep the immune response in check and in control so that it doesn't go out of control. When we talk about HLA and in the context of transplant, what are broadly the two things that we are looking at? We are looking at HLA type, anti-HLA antibodies, and what can predict graft outcome. We are interested both in the direction GvHD and in the direction of rejection. So, for example, if the donor has HLA that is not there in the recipient, then you say it's a direction of the graft being rejected. On the other hand, if the recipient has a HLA antigen that is, or an allele that is not there in the donor, you're looking in the direction of GvHD. And occasionally it can be, or more often, it can be bidirectional, both in the direction of GvHD and rejection. Now, when it comes to stem cell transplantation, for the longest time, we could not cross what is called the HLA barrier. And a disparity within the HLA system presented an important barrier. Therefore, it was very important for us to have high degree of HLA matching to have both engraftment and prevent GvHD. And all the early transplants in the 50s and 60s had a high risk of engraftment and GvHD because they really had very little technology to really have the depth of HLA understanding that we currently have. And so it's important to remember that mature T cells from the donor respond to mismatched MHC class molecules on the cells of the recipient. But even the cells of the recipient are presenting antigens through antigen-presenting cells from the recipient. And they are presenting to the mature T cells that are coming in. And therefore, they recognize the recipient as being foreign and they cause GvHD. Now, in the reverse direction, again, the recipient's antigen-presenting cells are what is actually presenting antigens to the T cells of the recipient. that have survived the conditioning regimen, for example, to lead to allograft rejection. So the antigen-presenting cells from the recipient can both cross-present and directly present antigens to their own T cells or to the incoming T cells. This is one of the mechanisms by which we think early ATG or other therapy directed at antigen-presenting cells. Remember, antigen-presenting cells tend to survive most conventional conditioning regimens. So therapies directed at antigen-presenting cells like ATG given very early, for example, may reduce the GVHD not by just T cell depletion, but also by decreasing antigen-presenting cells in the recipient. And therefore, this is often a balance between graft rejection and graft relapse and GVHD. It's easy to talk about with these simplistic terms, but actually it's very complex. So old data, looking back, this is how a mismatch and transplant outcome looked. If you had the cumulative instance of GVHD, it was literally a linear association. Every single loci mismatch led to a cumulative increased instance of GVHD. And therefore, in that era, and even today, we generally say that for HLA typing, for a matched sibling, if you have even low resolution of AB is fine, you have DRB1 at high resolution, and that's because it's a matched sibling. The probability of there being, if the haplotype runs true, there's a high probability that the matches will be complete. You really don't need to go to high resolution. The same goes for haploidentical when the donor is from the family. But as soon as you reach a matched unrelated donor, because the haplotypes where these originated can be completely different, you should have high resolution DNA typing. But again, as I said, a lot of this is today really theory, because most of us have high resolution typing for every type of transplant, and nobody's trying to save money by doing low resolution typing. For a matched sibling donor transplant, a HLA identical or fully HLA matched sibling is considered the optimal and first choice for graft. And that has not changed. I would say that even today has not changed. The recipient and selected sibling should be 6x6 match. If it's a sibling, HLA-B DRB1 is sufficient, because we can assume that the haplotype runs true. And if even if you had at this level, matching is adequate. In the absence of family typing to establish family haplotypes, high resolution typing of DNA of HLA, BC, and DRB1 at least is required. If not, additional DQ, DP1. One antigen mismatch related donor, the donor differs for the recipient by a single HLA antigen. It could be a sibling with a crossover or very certain other unusual situations. Here, there's a lot of controversy about what should be the mismatch that's acceptable. And as I'll show you in a crowded slide, none of that really holds true in multiple studies. But let's just look at an older data. This is from 1993 to 2006. And I intentionally take this large data set. I try to take as much as possible large registry-based data sets to prevent single center biases. In an era where there was not all high-resolution typing, clearly between a matched sibling donor and an unrelated donor, there was a cumulative increase in the incidence of a GVHD. And a mismatched related donor had a higher incidence of mismatched related donor, have cumulative incidence of grade 3, grade 4 GVHD. But between a mismatched related donor and an unrelated donor in that era, there was still not that much difference between treatment-related mortality, overall survival, and chronic GVHD. A matched sibling donor on all fronts was better. So even with the relatively low or not a complete high resolution typing, this was how the data looked. But actually, even with high resolution typing, those differences have become less between an unrelated donor and a single antigen mismatch unrelated related family donor. The survivals are the same. Still, the acute GVHD risk, not statistically significant, tends to be a little higher in a mismatched related donor, even a one antigen mismatch, as is the risk of graft rejections. Our own data looking at a similar phenomena, here this is between 1995 and 2015. So the earlier era in this would have had at least AB done by serotyping for a significant proportion of patients, and class 2 would have been in high result typing. We are looking at matched sibling donors, and this is a small fraction taken out of almost 1,400 to compare age and disease and risk matched groups. compared to matched family donors and mismatched family donors. So matched family donors and matched sibling donors would be HLA identical. So expecting a difference between a matched sibling donor and a mismatched family donor is perfectly understandable. But what is striking is that there is also a difference when there's a fully matched family donor. And that's what the data showed us. The rejection rates were higher with a matched family donor, slightly better than a mismatched family donor. But even then, the risk of graft rejection, GVHD, all was slightly higher in a matched family donor compared to a matched sibling donor. And that translated to impacts on survival between a matched sibling donor and a matched family donor. Agreed that this data was an earlier era. So if we look at fully matched 10 by 10 matches of a matched related donor versus a matched sibling donor. So here we are not talking about any confusion with regards to HLA typing. We are looking at patients with only thalassemia, and we are looking at matched sibling donors. We've just taken a cohort of them for comparison, age and risk match, and another group who are 10 by 10 matched related donors, non-sibling, but 10 by 10 match. Remember, there will always be, when you do an analysis like this, it's very difficult to get large numbers, and there'll always be caveats. The 10 by 10 match-related donors will have donors who are much older, as can be seen over here. That median age was 36 versus 6 years of age, and they will tend to be patients who are higher risk. So here we have matched with them, and our observation was even in this setting, there was a slightly higher instance of graft rejections in the 10 by 10 match-related donors compared to the matched sibling donors. The majority of this being high-risk group of patients, and the 9 by 10 clearly had a higher risk of graft rejection. So while we tend to say, a matched family donor is exactly the same, it's not really true. So one has to be careful. Again, I wouldn't say this is the final stay of this. With improvements in conditioning, with PTCY, with other interventions, possibly this could change. But one should be conscious that there are factors more than HLA that have an impact on outcome. And we'll talk about that as we go along. So now, looking at large registry data that has looked at the same thing. This is a large thalassemia registry data with almost 1,110 patients through almost all continents in the world. Here, the impact of age we're all familiar with. But again, look at the impact of mismatched relative versus a matched unrelated versus a mismatched unrelated. We don't have a matched relative non-sibling in this particular analysis, but you can clearly see that the mismatched relative, if you take the way this graph is generated, this is the hazard ratio of 1 for a donor matched relative donor. So this would include siblings and non-sibling matched relative donor with a hazard ratio of 1. A mismatched relative donor has a 3.03 times increased risk of graft rejection and overall mortality. So that runs true even in registry data. However, the caveat here is, remember that this did not include haplotransplant, did not include any alpha beta depletion. So those interventions in the context of this could potentially change it. So those were not included in this analysis. Coming to a mud donor, the overall survival is increased and transplant-related mortality reduced with recipients of unrelated donor hematopoietic stem cell transplant evaluated and matched at high resolution for HLA-BC DRB1. This is well established and well known. When an 8x8 matched adult voluntary donors are not available, then a single HLA locus mismatched donor can be considered with acceptable risk, especially in the context of malignant conditions, where there is really not that much different notice, but I would be cautious in conditions where there is an inherent risk of graft rejection. And some of them will look heavily transfused patients with thalassemia, aplastic anemia as illustrations of that. We are also aware that the chance of finding a matched unrelated donor, especially a 7x8, is quite good in most populations. Obviously better in the Caucasian than in the non-Caucasian population. This is the crowded slide that I said that I'm just putting up. I really don't want you to spend time on it. But basically, the associations that have come with HLA are all over the place. The early CIBMPR analysis, for example, showed high incidence of poor outcome with class 2 and a better outcome for example, with class C, but that was with bone marrow. When they looked at PBSE as the source, the findings were completely different. The findings also vary depending on where the data comes. So the Japanese data will look very different from CIBMTR data. So there are lots of associations that have been reported. I think the broad take-home point is, as much as possible, you want a fully matched donor. And to say that this mismatch is better than that mismatch is really not something that really is that relevant. The understanding of permissive and non-permissive mismatches is important. And you really have to rely on your HLA lab to give you that. What about a 9x10 versus a 10x10 mud? This is a common query. The earlier data, again, from the CIBMTR, the HLA mismatch had a significantly worse outcome. This is large registry data. I'm really taking large registry data again to take away all the biases of single centers, etc. So clearly 7x8 did better, did slightly worse. And so what about when it comes to malignant conditions, especially in the context of high resolution typing and more recent data? Here again, you can see that 10x10 did better than 9x10, did better than 8x10. But here is where it becomes confusing. This is again a fairly large database. The second one is actually from the German database, which involves more than 3,000, 4,000 patients. When you impute age onto this, you can see a 10x10 less than 30 years has a better outcome than a 10x10 greater than 40 years. And we start looking at a 9x10 less than 30 years of age versus a 10x10 more than 40 years, the outcomes are almost similar, showing the interplay between age, mismatch, and HLA typing. And I'm sure that there are other players and larger data sets that you analyze, you'll find these kind of associations. So here, for example, this is another data set, again, from the EBMT, fairly large data set, looking at unrelated donors and matched related donors, less than 39 and more than 39. You can see that a match-related donor, more than 39 years, had a significantly worse outcome. The donor age is more than 39 versus an unrelated donor less than 39 years. So age is an important co-variable when it comes to HLA matching, and this should be kept in mind. This is one of the largest data sets that try to look at the impact of age and predicting outcome in HLA matched transplants. This is again a CIBMTR data. You can see very large numbers, fully matched 2,216. Oh no, I'm sorry. Age 18 to 32 was the largest group. Donor age 33 to 50 years, 3,651, and more than 50 years was seen. So if you look at all were HLA matched, if you look at the outcomes, you can see clearly the younger patients statistically did better than patients where the donors were older than 32 years of age. So from this study, without getting into the details of it, for every 10-year increment in donor age, there is a 5.5 increase in the hazard for overall mortality. Increasing HLA disparity was also associated with worsening survival at this analysis, as shown on the original graph. Donor age and donor recipient HLA match are important in selecting adult unrelated donors. Other donor characteristics such as sex parity and size in this analysis did not impact outcome, though there are other analyses which showed that even an ABO matching actually did seem to improve outcome. So in addition to this, testing for additional HLA loci like DPB1, DQB1, others could assist in better donor selection when all other parameters are matched. And permissive mismatches and understanding of permissive mismatches more in the context of HLA DPB1 is important. Based on the findings, younger unrelated donors found to be associated with less acute GVHD and better overall survival. And there is some data to say that ABO-compatible donors were also associated with a better survival, so the strength of the association was less. Without getting into the details, some of the areas where we often look at is when a 10x10 match PBSE or bone marrow donor is not available, a single mismatch at A, B, C, DRB1 or BQ1 is acceptable. It's a fairly high-level recommendation. And the other one is for unrelated donor selection, HLA DP1 typing should be performed when a choice of otherwise equally matched and appropriate example is available. And there, if possible, we should get a DPP1 matched donor as well. May not always be possible. Then comes the era of post-transplant cyclophosphamide. Again, this is a focused audience. All of you all understand post-transplant cyclophosphamide. This has really turned the HLA field upside down in many ways and really changed the challenge of doing transplant across HLA barriers to a large extent has been possible because of post-transplant cyclophosphamide. This, you remember, prior to PTCY, this is how a mismatch, every loci mismatch looked. And today, with post-transplant cyclophosphamide, GVHD is not impacted by HLA mismatches. That's a very big statement, but that's fairly true and very robust. Grade 2-4 GVHD, grade 3-4 GVHD, chronic GVHD are all very low. All this does come with a price. It comes often with a slight increased risk of graft rejection, a slight increased risk of poor graft function, and delayed immune reconstitution, leading to increased viral reactivation. And various strategies have been done to address each of them, which I won't go into detail. But probably PTCY is the most effective GVHD prophylaxis regimen. It has made T-cell repeat haplostem cell transplants feasible. The mechanism of actions, I won't go to it. What we really want to know is the efficacy of PTCY in the context of haplo with MAC, RIC, non-myeloablative, bone marrow, and PBSA has been well established with an overall low instance of GVHD. And these are figures that one can expect. Less than 20% grade 3-4 GVHD, chronic GVHD, less than 20%. In the context of pediatric patients, this will probably be much less, because generally in pediatric patients, the incidence of chronic GVHD and even acute GVHD tends to be less. There is an increased risk of graft rejection, and there is also increased risk of viral reactivation. So this is data just as an illustration, but as all of you are aware, there's multiple single multi-center registry data that basically shows similarity in the outcomes of match sibling, MUD, and haplotransplant. So in this paper, they try to look at the impact of, but there are very amount of variables. One must remember that, and those are often not accounted. So, and therefore these observations and these different studies cannot often be compared with each other. In this particular large CIBMTR-based registry study, they tried to look at the impact of match and the impact of matched myeloablative versus reduced intensity conditioning. Without belaboring the point too much, basically what they showed was that in the context of a haplotransplant, in the context of a malignancy, there was really not much difference between a myeloablative and a reduced intensity conditioning. There was a trend to a slight increase in the lapse, but did not translate to an improvement in overall survival. So that's something that we keep it in mind. Our own data with AML, just to show you that our MUD and haplo data really doesn't look very different. They're fairly mature long-term data that the entire cohort and patients, even beyond CR2, the outcomes between our haplo and our MUD transplant data looks very similar. Now, mechanisms of graft rejection, especially in the context of haplotransplant, could be cell-mediated. We don't talk too much about it. We often focus on the antibody-mediated graft rejection and the complement system. Without getting into too much details, we'll talk about antibodies. And these antibodies in HLA don't automatically appear as the ABO system. And some of the reasons is the ABO system are glycoproteins, and this cross-presentation of other antigens that can then mimic these ABO antibodies that we often develop naturally. The HLA antigens are all peptides, and unless you're actually exposed to that particular peptide, either during pregnancy, transfusion, or some other way that you're exposed to the antigens, you don't automatically develop these antibodies. So anti-HLA antibodies, you have to be exposed to them by one of these mechanisms. Only then can you develop the antibodies. And if you do develop the antibodies, it's more likely to happen in patients who have been heavily transfused or, in those kind of situations. And the data varies widely, and a lot of that relates to a large extent also because of the platforms that have used their sensitivity, etc., but varies anywhere between 14 to 18% or 20% in the context of haploidentical transplant of donor-specific antibodies. So what is a significant level? This also can vary. Generally, we say more than 5,000 MFI in the context of a haploidentical, at least a T-cell replete, but ideally we'd like it to be negative. I think it's very, very important to remember that high DSA is associated with graft rejection. It does not mean that everybody will have a graft rejection. And in fact, it's also important to remember the Luminex platform by which these values are generated was not actually intended for quantification. So there's very little poor quality control. And the probability that the values that are generated in 10 different labs being exactly the same or similar is actually not so good. A better way to quantify the antibodies actually flow cytometry based testing, where you can look at serial dilutions of the serum and look at the strength of the MFI that is generated. So there are various ways to look at anti-HLA antibodies. Ideally, we should do both the flow cytometry based and the antibody method that we use by the single antibody beads with the Illuminex platform. And the reason for that is, if you look at the single antigen bead method, it is a specific set of antigens that are expressed on beads with a unique fluorescent signature. And then you put the serum of the patient, and if it binds, the binding with the beads is picked up, and this is read out. Now, occasionally, not common, again, you have to work with your lab, the particular antigen that is there in your donor may not be presented in the beads that you have in your kit. And therefore, sometimes the flow cytometry may show a positive reading while Illuminex may come back as negative. Not common, but this can happen. Secondly, while the MFI is read out on the Illuminex platform, if it is also shows up on the flow cytometry, serial dilution of the serum can give you a better strength of that antibody than just the MFI value that you generate on the Illuminex platform. In patients undergoing a HLA identical transplant, DSA is a prerequisite to ensure a good donor. DSA negative donor is preferable. And there are various strategies which I'm just not going to go through. There are any number of strategies, and you should use the protocol that is published and that is well used. Everybody claims theirs is better. The broad principles are B-cell depletion using rituximab, bortezomib, plasmapheresis to get rid of the circulating antibodies, and with IV immunoglobulin replacement, plus or minus combination of additional immunosuppressants like tacrolimus. There are various strategies that are used to decrease. Please remember that many of these patients these studies that show the improvement in outcomes are based on small numbers. Statistically, there are very few large studies that have showed such a significant impact or a very consistent and reproducible impact of reducing the antibodies to X level or Y level. So I conclude by saying HLA still remains an important factor in transplantation. Many data show that mud versus haplodonor outcomes are similar, limited by, especially in the context of haplo and donor-specific antibodies, by absence of large data that have addressed this in a prospective fashion. Haplotransplant, while equivalent in outcomes, is associated with increased viral reactivation. There are increased challenges with it. If time permits, relatively elective, one would prefer a 10/10 mud. That's my opinion. If urgency and CR2 and beyond, the haplo probably an option, especially in the context of malignancies. The cost analysis is something that will depend, and center-specific preference and experience is a very important factor in deciding the transplant, the HLA type, the amount of mismatch you'll expect, the donor age that you'll expect. But basically, better matching, less donor-specific antibodies, younger donor age are fairly robust statements that one can say is associated with a better outcome. I'll stop here. I'll be happy to take it. Or I'll take the panel discussion.
Yes, sir. Thank you so much, sir. It was a very lucid and very insightful talk on such a crucial, important aspect of hematopoietic stem cell transplants, HLA. So I'm sure all of us on this, we have more than 100 plus attendees on this virtual dais. So wonderful. So I think we are out of time, but I cannot resist asking a couple of questions from this very interesting and very insightful discussion. Sir, the common questions on behalf of the audience I will ask. So when you have a choice of a match sibling donor versus full match unrelated donor, and the sibling is above 55 years old, so what will be your preference? That is number one. Number two, most of us now are with the thought that haplo outcomes are as good as full match MERD outcomes. So is it so? So in a patient where you have a choice of 10 or 12 by 12 MERD versus haplo family donor, which will you prefer? And the last question, amongst the multiple haplo donors in the family, do you use that haplo selector tool, which takes into, after that Fuchs paper in 2021, so the B leader score, DRB1 and DP B1 T cell epitope, that score complex algorithm, which shows differences as high as 10% with regard to various haplodonors in the family. So if you can answer this, it will be a great learning for all of us.
Okay, so your first question, clearly the data shows that a young, fully matched unrelated donor outcome is superior to an older matched related donor. In this case, you said 50 years is the donor. That's the data. But the reality is on many other aspects, including the finances and the cost, etc. And therefore, for that reason, sometimes we may not always go with a matched unrelated donor, but the data would suggest that a younger matched unrelated donor, say less than 20, for example, or less than 32, for example, has a better outcome than an older matched related donor. The second one, personally, I would, if I could, if time is not an issue and all other factors being constant, I would choose a 10 by 10 over a haplo transplant. A conventional T-cell repeat transplant is my choice. The overall, there are subtleties to this, and obviously center experience does matter. But there is generally a tendency to graft rejection, which is slightly higher. Much more important and less talked about is poor graft function. Many of the published data comes from the West, where the level of support that is available, whether it's letermovir, whether it's antivirals, whether it's CTLs, all that is much more. And those are challenges for us. The kind of viral reactivations we get can be challenging. Of course, there are strategies of CD45 additions and all that costs money. So if a MUD 10 by 10 is available, it will still remain my first choice. And the last question that you asked was about
selection of haplodonor based on the
so we don't
algorithm.
use that algorithm. When we did an NK cell trial, we were doing the B score, etc. We routinely don't use it. When we were having our NK cell trial, we were using that. I know that there's published data that shows some difference. On a routine basis, often we don't use it. We just go for the youngest male donor as much as possible that is available and who's DSA negative. That's our primary driving factor.
Thank you so much, sir. Thank you so much for the wonderful session. And I hand over to the next panel discussion. So thank you so much, sir. And thank you, everybody, for this wonderful applause.
Thank you, Dr. Ganesh. Am I audible?
Yes, madam.
Yes, you are.
Okay. So sorry, my video is somehow not working. So I'm just going to present like this. So after interesting, excellent talk by Dr. Vikram, and we all know that HLA is a crucial thing in selecting the donor. First and foremost thing what we look at is HLA typing while selecting the donor. And there are many other factors other than looking at the HLA donor, though it is most important thing. So we will look at, sir has already highlighted a lot of important aspects, what we need to look at in HLA typing. So we'll also go through some of the other factors and how I just kept it very practical, where how we need to select the donor and what are the factors that influence different diseases. So before moving on to the questions, just a little bit of history, we all must be aware, some of you must be aware, when it was first done, first successful transplantation was done between identical twins in acute leukemia by Donald Thomas, which he has won Nobel Prize later on, and then first HLA typing and first sibling transplant was done in 1968. He also won the Nobel Prize later on. And then we also know the other milestones of doing first thalassemia transplant and cord blood transplant subsequently in 81 and 88. Dr. Vikram has already highlighted all the basics of HLA typing, class 1, class 2 molecule, where they are located, how we read them, both antigen, allele, and coding regions, different proteins, everything he has explained. So we'll just go into the questions I think I'll skip the first question because sir has already highlighted on these aspects, like, what I have kept it as a first question, that is different classes. So he has highlighted on different classes as well as how the methods are done also he has highlighted. I'll skip that first question. I'll move on to the second question. That is like, Dr. Ruchira, are you there? Dr. Ruchira Misra? Yeah. So we'll move on to the second question. That is, how do you choose the donor? What is the general algorithm while choosing the donor? Dr. Ruchira, over to you. Any transplantation,
Hi,
how
Dr.
do you
Sirisha.
choose?
Yeah. So Dr. Vikram sir gave a very lucid talk on about HLA typing. And as he said in his take-home points as well, the first thing you would prefer to use would be an HLA identical donor, and preferably an HLA identical sibling donor if that is available or not. However, if that's not available, then an HLA matched related donor or a 10x10 matched unrelated donor would be given preference. So that becomes the first choice that we would generally think of. So the HLA matching needs to be as identical or as close as possible is what we are looking at. But once we've got that and we still have multiple donors available, then a younger donor, so donor age becomes very important. Subsequently, CMV matching. In India, most of us are CMV positive, but in the West, because you still have CMV negative donors or CMV negative recipients as well, we need to make sure that there is a CMV matching there, especially that the donor should not be negative in the presence of a CMV positive recipient. Then sex, usually a male donor is preferred over a female donor, especially if females are multiparous. And if there's a male recipient, then also a male donor would be preferred over a female donor in those patients as well. Last but not the least is probably ABO matching. Generally, we don't look at ABO matching as much, but if you were looking at a bone marrow graft as a source of collection of the stem cells, then yes, you may think about choosing an ABO compatible donor as well, provided you get the other factors right as well. And if you don't have any of these, if you're not looking at that, then a haploidentical transplant or a mismatched unrelated donor transplant could be thought of. I personally would prefer a haploidentical family donor over a mismatched unrelated donor.
So,
I hope that answers.
Yes, Dr. Ruchira, absolutely. So that is the algorithm most of us follow. Dr. Sandeep is not here. He has some personal commitments, so he's not here. Vikram sir, can you please take up the next question? What is the importance of DP? I think you have already explained. Can you just brief on that?
Yeah, so for the longest time, we didn't give too much attention to DPV1, but I think if you have two donors and if you have the opportunity to identify a DPV1 match, it will be preferable. The data itself is a little confusing depending on which data set you read. In some data sets, it doesn't make much of a difference. In some, it does. And the second important thing is there's a fair number of DPV1 permissive mismatches. And the knowledge of that is important to not react to it and then proceed with the same. But there are definitely studies that show some survival advantage of DPP1 mismatching as well.
Absolutely, sir. So whether it is, we are looking at, especially when we are transplanting thalassemias, whether you are looking at DP non-permissive or permissive, that does make a difference in GVHD and all. So, Dr. Rasmi, can you highlight the importance of DSA in when you are going for haploidentical transplantation, which many of us are going ahead and doing nowadays, as we know, like, availability of the sibling donor is only 25%, and match related, unrelated donor register has to pick up in a big way, not like Western countries. In our country, it is limited going by that, as well as some of the constraints in procuring the unrelated graft. We are going ahead with haploidentical transplantations in many of the cases. So can you highlight the importance of DSA?
Sure. Yeah, thank you. Thank you so much, Dr. Sirisha, for the question. So donor-specific antibodies are these antibodies that the donor develops against various HLA antigens that the donor's immune, so the recipient develops against various HLA antigens that, the recipient gets exposed, during transfusions, during pregnancy, like that. So the key here is that if the recipient has actually antibodies against any of the incoming donor stem cells, then there is a high risk of rejection. So the assay that is most sensitive and most of us routinely uses the single antigen be the SAB assay. And it gives us a fluorescent titer measurement to quantify these antibodies. So most of the time, anything more than 200 or 300 are reported. And depending upon which transplant group or publication that you go by, most people think of about 2000 as significant. Some people say more than 5000, but I think a significant titer sort of excludes that particular donor because of the risk of rejection. The donor, the DSA desensitizing strategies, there is data, there are, there is actually an EBMT consensus paper that came out on it by Dr. Churia. But then the bottom line is that you would always prefer a donor against whom you don't have any DSA rather than desensitize, the recipient. Coming to desensitization strategies, we ourselves have some experience having done about 14, 15 odd desensitizations for titers more than 5000. We felt that the younger patients tolerated these desensitizations better, but again, our number was not significant to say that a particular desensitization strategy put the patient at a risk of something. But in general, a high titer DSA, predicts a higher TRM in these patients due to graft rejection and such things.
Absolutely. We always prefer to change the donor, but at the same time, presence of DSA is not a contraindication to go ahead with the donor, as we always follow the desensitization technique. And many of us are comfortable with the levels of 1500 to 2000 rather than like keeping the cutoff of 5000, as I think many of you agree with that.
Yeah.
So Vikram sir, can you nicely explain antigen allelic matching, importance of that, and then different regions, coding region, protein region, all those things. So can you please elaborate once again on that? It's an important point.
On the what? Elaborate on?
So matching of antigen as well as allelic matching. Antigen
as far as the data goes, there's really no major difference between saying an antigen mismatch is okay, while an allele mismatch is not okay. Both mismatches are equally bad. So there's no difference. Originally people felt that, an allele mismatch was more serious than an antigenic mismatch. I don't think that's true, really.
Yeah. Okay.
The donor-specific antibodies, I just want to say, for people who are sometimes stuck and if you have options, of course, you're trying to get negative. I think it's just kind of important to remember, especially it's a risk-benefit at the end of it, So if you have a relapsed refractory AML, you're going to transplant, there's only that much time you can do. So I would not take a 2000 level or even a 3000 level as an absolute contraindication for a transplant. And you should also remember the limitation of this MFI values that we swear by. Nothing is absolute. So even in the worst case scenario, in a person who has a very poor outcome, the risk of rejection is about 14%, for example. There's still a large proportion of patients who you will still have a successful transplant. So keeping the context of time and then waiting for 4 weeks to do and desensitization, if you're doing a pre and a peri and a post-transplant desensitization protocol, when time is of essence in certain diseases, I think you have to balance the risk-benefit and go forward.
So absolutely, sir. Especially in emergency transplants like leukemia, SCIDs, and these kind of scenarios, we do have to go ahead. Sir, can you if we move on to the other aspects of discussion, that is matched unrelated donor transplantation, where there are many challenges in procuring the donor or going for the grafts like bone marrow graft, and waiting time being more. So we just want to highlight few practical aspects. Vikram sir, can you highlight, like, how different donor registries in India and how they are maintained?
Oh man, so there are so many donor registries. I mean, all of you all know all of them. No? The usual ones that come to our mind is Datri and DKMS, and ones that you put up MDRI and all that. But the bottom line is, when we do a search, it usually goes to a network that is worldwide, and they will tell you where exactly the donors are available, and then you go to the specific registry of your choice. For us, it often boils down to a factor of cost as well. So, I mean, all of you all are aware that MDP donor costs much more than if we get a donor from DKMS or from Datri. So often that's an important driving factor as well in terms of things. The registries itself, they have to be professionally run. It's not a part-time thing. It has to be professionally run. They have large numbers of donor registry database to be functional. And actually, India, we need to be quite proud of our registries that are there in India. If you ask me, I think they're doing a pretty good job. Even with the relatively small numbers compared to the international registries, I think they are able to cater to a vast majority of the requests in terms of donor.
Yes, I do agree. Like, they are very prompt in responding about the availability of the donor and doing the workup for them and then providing the graft. So
Yeah.
I do agree with you. Dr. Ruchira, can you tell us, like, what are the challenges in procuring mud donor graft, and what is the preferred graft, and what are the challenges in getting bone marrow source in these cases? I'm combining Dr. Sandeep's question as well.
Yeah. So we know that most of these registries are basically either they're all voluntary. So the donors have to volunteer to be ready to donate their stem cells whenever the need arises. And a lot of the times these registries are working on drives. So the registry or some patient will kind of initiate a drive either in a college or their relatives and stuff like that. And then they get the people to kind of donate, to be ready to give their DNA samples so that a database can be maintained whenever the need arises. The problem, the challenge occurs is that a lot of these people are doing it for one specific person or patient when they're ready to, at that time, give their DNA for their data collection. And when that need gets fulfilled, they kind of often kind of drop out and they refuse to donate for somebody else. So a lot of times we face that the donors refuse and they give various reasons for refusal. Some of them legitimate, some not so legitimate as well. So that's one of the things that we find happening, that there's a lot of donor dropout happening there. The other challenge, as Sir mentioned, is the cost that is there. So getting a donor in India and being able to pay for it is far easier than trying to arrange for an international donor stem cells to be transported to our country. Though, yes, DKMS and the other registries have helped out, but it's very, very costly that we would do that. So in most cases, we would ask for a mud search. However, time also is important. And if I need to do an urgent transplant, say my leukemia is MRD negative and I need to do a transplant quickly, then taking about 3 weeks for a donor workup doesn't really make sense to us. And we would kind of go more for a family donor rather than waiting for the mud donor. For non-urgent transplants, would definitely prefer a mud over a family mismatched donor that is there. And in regards to bone marrow, so now when they're counseling these patients, the easier way to donate is through a peripheral blood stem cell collection. And that's how most donors are counseled at the initial stage. So when you counsel them for a bone marrow collection, or when you counsel them that you would need to undergo an anesthesia for the collection, there will be further dropouts there as well. And in India, at least, I know that more than 90% of the donations will be a peripheral blood stem cell collection itself. They will not be bone marrow. Internationally, it takes a lot of counseling, but yes, we've managed to get a few bone marrow donations also from our international donors that have come in. who are kind of very highly motivated. That's the challenge that is there.
Yeah, that's a very true. Like, the getting the bone marrow graft from the unrelated donor is definitely a big challenge here. And I have not heard anybody, getting from the Datri. I have not done that personally, I should say. But international donor, yes, we also got one bone marrow graft. So that, as you said, like it involves a lot of counseling and motivation. And there are scenarios where people do counsel, sometimes like, lack of awareness. Also, like people do counsel them to go for temporary rejection as longer period. Like we had one donor who is 10/10 match. He was ready, about to donate. Patient was ready. And then finally they said that he underwent minor dental procedure, and then doctor advised him not to donate for 3 months. As we tried counseling him, like, minor procedures are only 1 to 2 weeks, but they did
Yes.
not go for it. So those kind of challenges do arise, like family persons being like, not accepting or these kind of procedures or moving to elsewhere. So all those challenges do occur with the unrelated. That is the reason why we have haploidentical transplants that are like, happening at much higher rate in our country compared to MUDs. And this is just a picture which illustrates like, peripheral blood graft is the source of stem cell in many of the unrelated donor transplants. Bone marrow graft is like, very less in numbers. We have gone through this. So moving on to the this was disease specific donor selection. Vikram sir, can you please highlight, like, when you're transplanting acute leukemia, does your donor characters change, and what is the ideal source of stem cell you prefer? Is it still the same, like, what you have shown the algorithm?
You're asking for AML specifically?
Yeah, both ALL and AML.
Yeah, so broadly the strategy is the same. You want a donor which is, a match sibling donor still will be my first choice as much as possible, and a full 10/10 match donor if it's available. As I said, time is of essence in certain situations. So I'm not going to wait for the perfect mud donor. I would rather go with a haplo if time is the problem. That's one thing. And there is something to suggest that PBSC may be better, though the published data would suggest not, in especially refractory relapsed diseases than with the bone marrow. But overall, most studies show that bone marrow and PBSC have similar, if not better, outcomes with bone marrow. The reality is that getting bone marrow all the time is challenging for us in adults, and so we end up using PBSC much more in adults.
Sure, sir. Sir, can you also comment on, like, the precautions, like taking the monozygotic twin as a donor?
No. You never take a monozygotic twin as a donor. Never ever do that, because that's like doing an autologous transplant, essentially. And there is no role for an autologous transplant in most situations. There is the GVL is a very, if not the most important component of the transplant in the malignant setting for the most part, especially leukemias. So we would
Yes, sir.
We would never use
Just
a
want to highlight the fact that, we should not get excited with the 10/10 match in these twins. So, Dr. Rasmi, can you can you comment on, like, how donor selection is different in CML or JMML? As we all know, like in JMML, especially like 30 to 60% of primary disease relapse post-transplant is one of the known fact in different reports. So what will be the donor selection in these cases?
Sure. Thank you so much for the question. So I think even though both CML and JMML are, they come under the MPNs, but they are very different in terms of disease biology, the age at which they present, and the response to medications as well as post definitive treatment course. So obviously the age is a big factor. So most of the children with JMML are very young. when they present. So in fact, JMML is one transplant where we have a lot of data using umbilical cord grafts, and they do have pretty good outcomes without much incidence of GVHD, without much rejection risk. So majority of the studies on transplant on JMML have come from using either a bone marrow or a cord blood graft rather than PBSE. The conditioning also differs obviously for both. Whereas CML, again, if you transplant a pediatric CML in a blast crisis or AP who requires a transplant, as pediatricians, we are definitely more comfortable with bone marrow grafts. So we may prefer bone marrow, but majority of the CML transplant data comes from adults, and there is a whole lot of PBSE graft usage there with pretty decent outcomes.
Sure.
Yeah.
So, Dr. Ruchira, can you take up this question? Like, we also autologous transplants, what are the pediatric indications? What are the challenges in collecting these autologous graft, and what is the ideal timing when you will do, especially in neuroblastomas with pre-exposed chemotherapy heavily? Like, what are the challenges in collecting the graft in these children?
Yeah. So generally, the indications for an autologous transplant are very limited in pediatrics itself. And unlike adults, where they used to use autologous transplants for AML as well, we don't generally use autologous transplants for AML at all. Our indications for transplant would generally be neuroblastoma, where it's a standard of care. And then say in some settings where there are relapsed malignancies, where you may think of using autologous transplant, like a relapsed Hodgkin's or a relapsed hepatoblastoma, where you think, or a germ cell tumor, where you think you may be able to offer them cure with those as well. The challenge is that these are already heavily pre-treated. Therefore, the stem cell reserve is quite low, and often you may not get an adequate collection at all if you're just using GCSF in these patients. The ideal time to collect it would be within 2 weeks of the surgery for a neuroblastoma. So once the surgery is finished and they're discharged, you should start planning to collect their stem cells. And it may go up to about, say, 3 to 4 weeks post the surgery itself, provided the patient remains well. In most cases, we've had to use plerixafor, which is an agent in addition to GCSF, to be able to get the stem cells for this. And that has generally worked very well. But there have been a few instances where we've had to use 2 or even 3-day collections, or even resort to a bone marrow stem cell collection after failing to collect adequate cells with a peripheral blood stem cell collection also. So it can be quite tricky there. In most cases, what we've been doing is doing a CD34 estimation a day prior to the collection, so that we get an idea whether we need to do that. And almost about 90% of our transplants are getting the collections for neuroblastoma getting plerixafor.
Okay. Thank you, Dr. Ruchira. And at the same time, we also have to make sure that the disease is not there in the bone marrow at the time of collection, especially neuroblastomas and all having a tendency to spread to bone marrow. That also we have to take care that, the disease is under complete remission.
Yeah.
So,
sorry, that went without saying. Yeah.
Yes, yeah. So just a quick case, like, where I wanted to share, like, a 7 years girl who is transfusion dependent. Dad is 7/10, but he was homozygous pathogenic variant. Surprisingly, he was completely asymptomatic. We went ahead with him as a donor, but and did the T cell depletion. There was a primary graft failure. Then again, mom was 5/10. She was heterozygous, mismatch in all. Then we did T replete graft with her, and then she successfully engrafted, and then obviously developed chronic GVHD later. But that got control with the treatment, and then she's fine more than 1 year post transplant, and she's fine. So just want to highlight, like, the graft failures in these children. Dr. Ruchira, can you take up this question, like how to face graft failure problems in aplastics or Fanconi anemia children, and how do you do donor selection in these children?
So most of the times with an aplastic anemia, there is an urgency to transplant. So in most of them, we are looking for a matched sibling donor as the first choice. But if we don't get that, in pediatrics itself, I would prefer to go for either a MUD or even a haploidentical transplant over immunosuppressive therapy with ATG, especially if the child is very young, because ATG generally doesn't work there. Now, in terms of donor selection, as I said, so first would be a matched sibling donor and then a MUD. So matching would be very important. But when you're thinking of haploidentical donors, we generally would try to do a T-cell deplete transplant in these patients if we can. And because we know that T-cell deplete transplants may have a higher risk of graft failure for these patients as well. So we would prefer to have a T-cell replete transplant for these patients, and would also kind of try, and if we are looking at aplastic or Fanconi's, we would try and avoid using TBI as a conditioning regimen for these patients because of their risk of having developing malignancy, secondary malignancies in these patients. But yeah, a lot of these patients do develop graft failure, and that, especially with haploidentical transplants, is a very big concern there with us. So would definitely prefer a matched sibling. And then if I don't have a matched sibling, MUD, if I don't have a MUD also, then I would look for a T-cell deplete transplant for these patients.
Yeah, absolutely. My matched sibling, that too bone marrow graft, where you can cut down on chronic GVHD and acute GVHD and all, is a preferred mode. And of course, haploidentical, many of us go ahead and do for these children. In that, like, looking at
Dr. Sirisha, I wondered about that because a lot of our aplastics come with infections. And so if they have an underlying history of having had multiple infections, would you still prefer a bone marrow graft over a peripheral blood stem cell graft? Because I personally would then prefer a PBSC over a bone marrow.
So in the sense, obviously data, Vikram sir also can add to this. Data clearly says that, chronic GVHD incidence is definitely less compared to PBSC for bone marrow. And of course, to some extent, acute GVHD incidence is also quite significantly less. So going by that, we do go ahead and use the bone marrow graft, especially for aplastics, where 10 by 10 is this match. But haploidentical, yes, as you said, like, the risk of rejection, especially for aplastics, is being high more in T depletion compared to T repletion. So we do see risk of graft rejection more in aplastics. There, like, definitely PBSC, we do go ahead rather than the bone marrow. So moving on to next question, Dr. Rasmi, can you comment on, I think partly this has been answered. Can you just say, like, highlight how the transplant is different in aplastic versus Fanconi in terms of donor selection and then doing the source of graft and all?
Yes. Like you said, Dr. Sirisha, Dr. Ruchira already sort of talked a little bit in terms of like what kind of donors are ideal for Fanconi versus an acquired aplastic anemia. So I'll just move on in terms of like the rest of the transplant characteristics, how they're different. So here we are comparing Fanconi with an acquired aplastic anemia, right? Not Fanconi versus other inherited bone marrow failure.
No, idiopathic. Yeah.
So idiopathic. So I mean, again, the causative mechanism is different in terms of how aplasia is caused in both. Like, acquired aplastic anemia is it's a T-cell disorder, whereas Fanconi's anemia is a stem cell disorder where the stem cells have this mutation and because of which the DNA repair genes are defective. So when it comes to the need for transplant, if it is an aplastic anemia, we actually grade the acquired aplastic anemia, we grade the severity. And, unless they are transfusion dependent and a severe or a very severe phenotype, we can actually conservatively manage them. Whereas in Fanconi anemia, we don't necessarily, they may become pancytopenic, but we don't necessarily wait for them to become transfusion dependent before the transplant, because there is this risk of evolving into MDS or an AML with these patients. So you transplant them before the transfusion requirement necessarily sets in. Then when it comes to the conditioning part, because Fanconi patients have this inherent DNA repair defect, the conditioning has to be kept in mind to cause minimum toxicity to the other organs. So especially when you use drugs like cyclophosphamide. So fludarabine doesn't have so much of an issue. We use similar doses in Fanconi children as other normal children. But when it comes to use of cyclophosphamide, the doses that we use are much lesser than what we would use for an acquired aplastic anemia. Almost always, especially when we are using mud or when we are using haploid nickel transplant, whether T-cell deplete or replete, we incorporate rabbit ATG into the conditioning of Fanconi because of the higher risk of GVHD. Then the donor part, Dr. Ruchira already highlighted, a sibling donor is preferred, and this is one situation where an unrelated donor whose full match may be preferred over a haploid nickel donor in Fanconi, just because you don't want to get into the complications of giving a PTCY in this Fanconi child. If that is the case, then a TCR depleted graft would be preferred. But we have data on PTCY where we have reduced the PTCY dose in half and given with acceptable survival. The other component is the use of radiation in Fanconi transplants, where a lot of centers try a radiation-free transplant. There are situations where we give like a very low, a single 2 gray fraction in these Fanconi conditioning. Then post-transplant, there is definitely a higher risk of GVHD in Fanconis after haploid nickel transplant, especially if you use T-cell replete marrow. That's probably all I can think of right now.
Yeah. So another point I just want to highlight is like Fanconi anemia being like, DNA repair mechanism being defective. They cannot handle the GVHD at all.
Yeah.
So we are aware of it. Do you prefer in vitro T-cell depletion for those children?
So
and PTCY?
Yeah, so in an ideal scenario where finances is not an issue, I would actually prefer, and and there is no high risk of graft rejection with some DSAs or other reasons, I would prefer in vitro T-cell depletion, just so that you can avoid PTCY, because there is again the concern for later malignancies as well, as you take this child through so much of cyclophosphamide, this Fanconi child through so much of cyclophosphamide. So yes, I would prefer T-cell depletion in vitro.
How about idiopathic aplastic anemia, haploid identical? Do you prefer in vitro or in vivo?
So with other aplastic anemias, we ourselves have our own center experiences that especially younger patients, younger than 30 years, do fairly well with PTCY using using in vitro T-cell depletion, in vivo T-cell depletion rather than in vitro.
So I completely agree. We also follow the same policy like idiopathic aplastic do in vivo T-cell depletion as risk of rejection being high in haploidentical with in vitro T-cell. And for Fanconi to cut down, to handle GVHD in a better way, in vitro in better mode. So moving on to benign disorders, I think having like CMC doing so many thalassemia, like largest number of thalassemia transplants in the country. Vikram sir can throw a light on like challenges in transfusion dependent anemias like thalassemias in these children. What is the ideal graft? What is their experience and all? Vikram sir.
Yeah, so the policy we follow is we use bone marrow for our low-risk patients, but we do use PBSC for our high-risk patients. We use a thiatipa trio with a PBSC for our high-risk, class 3 high-risk patients. Our own experience is the graft rejection comes down significantly, but that's not the international opinion, but I'm just telling you our practice. For low-risk patients, we stay with the conventional BSI and bone marrow grafts.
Okay, sir. Dr. Ruchira, can you comment on skip transplants in terms of like, timing and donor selection and challenges in procuring the donor in these children, especially mud? I don't think we can wait for mud at all in skids.
Muds at all. Yeah. So normally with kid transplant, there's always an urgency to transplant because they're at a risk of getting infections very, very quickly. And most of them are diagnosed when they get recurrent infections itself. So that becomes a big challenge to how to take them up for transplant as soon as possible after getting their infections under control. To such an extent, they may not completely eliminate it, but just get it under control to be able to do the transplant. And there is data to say that when these children are transplanted earlier, they do much better if they were diagnosed early and transplanted early, say around 3 to 6 months of age, versus when they get transplanted usually around 6 to 12 months or beyond 6 months of age. They do not do so well. However, if they are transplanted early, their survivals are in the West at least up to as high as 90% in these patients. But a lot of our children, because of delays in transplant, because of these persistent infection, delays in diagnosis that happen in these patients, there may or may not be a family history to kind of give an inkling that this may be a SCID initially itself, may actually be one of the reasons why they may not get transplanted. And often there is also,
5 minutes. Yeah.
when you have young children, when you have infants, they may, I have kind of felt this as well, that people are willing to let the newborn go or the infant pass and think about planning another pregnancy rather than spending the finances and trying to cure these patients. So that often becomes a big hindrance there as well. I think probably if we were to have neonatal testing done, that would be the fastest way to pick them up early, and that would help us in these scenarios where we could counsel them quickly. Delays also happen because it takes about 2 weeks to get an HLA typing done for these patients, and then to plan a transplant for them. So the best would be if you had a match sibling that you could pick up very quickly, or otherwise you often think of using the maternal stem cells itself, and you do it. In most cases, you could also try doing it without any pre-transplant conditioning being offered to them, and you just give the maternal stem cells if the child, especially if the child is very sick. But again, there are data to say that if you do give them pre-transplant conditioning, they tend to have better survivals than if they're given without any conditioning there as well. So so earlier diagnosis, earlier referrals, and faster techniques to take them up for transplant, quicker diagnostics would definitely help them to improve our survivals in our country.
Yeah. Thank you, Dr. Ruchira. I think in the best interest of time, we'll quickly go through the questions, and just want to highlight in the especially importance of metabolic or genetic conditions like adrenoleukodystrophy and all. When you are transplanting, we recently had 10x10 mother. So someone has done the HLA typing of mother as well. Like she was 10x10, but dad was 5x10, 6x10, I should say. So those kind of precautions we have to take at the same time, even for immunodeficiencies like, Brutans when you're transplanting. So those kind of precautions we have to keep in mind. And there are some temporary donor rejection factors, which are listed in most of the recommendation, the EBMT books and all, you can find it, as well as the permanent rejection factors with chronic diseases. And donor assessment is very standard. Just few things like what I wanted to highlight is about the ABO-RH incompatibility. Once we have 10x10 match, Vikram sir has already spoken about the importance of, elaborating on kid mismatch as well as ABO-RH incompatibility. If you have multiple donors, then you will choose ABO-RH compatible rather than non-compatible donor, as well as other characters like younger the donor, better the survivals, ABO compatible, and kid mismatch also he has highlighted already. And moving on to the take-home message, and there are some certain donor characteristics I want to just highlight. 10x10 match, CMV seropositive donor for seropositive recipient, seronegative donor for seronegative recipient. Bone marrow as a stem cell source is always preferred, but there are few exceptions where we go for peripheral blood, but majority of us are doing peripheral blood. Younger the donor always preferred, male donor preferred, and ABO compatible wherever there is a choice. So this is what we need to keep in mind. And definitely few points to highlight in mud transplants is in malignancies, mud is not inferior to matched sibling donor. That is what we all know the urgency of it, and then we have to go ahead with it rather than waiting. And in non-malignant disorders, bone marrow is the preferred graft. We have to spend time in counseling the donors rather than rushing with the peripheral blood as a source of graft. And finally, I just want to conclude saying that, transplantation has to be done ethically and abiding to all rules. Thank you.
Thank you so much, Dr. Sirisha, for that wonderful and insightful discussion. There are some very intriguing questions on the chat box. So I will request Vikram sir and all the eminent panelists and Dr. Sirisha madam to be on board. Just a couple of minutes. So Dr. Rajat Bhattacharya sir asked a question to Dr. Vikram. Wonderful talk. As host APC, the major reason for GVHD, why should we always give ATG distal to the graft? That will help in CD4 recovery post-transplant, which has shown to be a good independent predictive factor.
Yeah, I don't think any of this is absolute. So while antigen presenting cells and the ATG, this is just one of the reasons why the ATG is given early. The late onset ATG, especially in the context of conditions like aplastic anemia and other conditions with an increased risk of rejection, the more distal you give it, there is a slight increased risk of graft rejection as well. So it's a combination of factors. The CD4 story, I'm not completely sure about. Maybe he can answer it. He may have that idea about it.
Thank you, sir. So I hope that answers Dr. Rajat's query. So Dr. Vipin Khandeval, sometimes we see antibodies in the DSA against recipients' own HLA antigens. Do these antibodies against own HLA antigens have any significance? Dr. Vikram, sir?
To be honest with you, I'm not sure about the answer. My answer is I don't think so. But I've not seen any data, so maybe it'd be good for somebody to do a data search on that.
Thank you, sir. And the last one, Dr. Ravi Joshi, role of PTCY in MUD. I think the next one we mismatched related donor, knowing that acute GVHD is higher in both compared to MSD.
Yeah, so this is a tricky one. We ourselves have published data in aplastic anemia matched sibling donor transplant with PTCY. The results were quite good, but we've still not essentially put it into real-world practice because outside the study, we still tend to use export methotrexate. As I said, PTCY is very effective in certain aspects, but there is a certain price to pay for it. So it's a bit of a trade-off. There are studies that show PTCY with better outcome even in the MUD setting. But I would still be a little cautious at this stage, Don't jump into that just like that.
Sir, like going by the same question, I'm sorry.
While it is a mismatched MUD, it is a 9/10, I would not hesitate to go with the PTCY. But a fully matched MUD, even though there's some published data to suggest that the outcome is better, I would still be a little hesitant.
Okay, sir. So because there was a lot of evolving data on...
No, there's published data showing it's better.
Yes, sir. Even in the matched sibling donor transplants for acute leukemias, the outcomes in terms of GRFS was significantly better.
Yes, I'm aware of that data. But what I'm saying is, please look at your own center's data. I think sometimes looking at published data, I personally believe my own data than I believe any published data because the real world of what we live in, what we deal with is always different. And a lot of the interventions that go to sustain and give these very good results is missing in the fine print.
Yes, sir. So thank you so much, Professor Vikram sir, Dr. Sirisha madam, and all the eminent panelists. It was a really learning experience for all of us. A lot of practical take-home messages, and I really thank the SPCTT for this wonderful academic opportunity. And I hand over to Dr. Satyendra Kateva for concluding remarks.
Thank you, Vikram sir, and nobody could have done justice the way you have done. Thank you, Ganesh, Sirisha ma'am. Thank you, Dr. Ruchira, Dr. Rasmi. I just want to say that please, everybody, whosoever wants to read about this ATG story, please read Dr. Jaap Bolan's paper 2-3 times. Every paper 2-3 times, and read the exposure and the outcome onto different cell. And still, I'm telling you, you will be more confused, but you will be much wiser. And I can tell you this rejection thing is absolutely true. Even the CRS, I think, is something which we need to look at. We are already, I'm trying to dig up the data. And this has been a wonderful, wonderful 1 hour and 50, not more than that, 1 hour and 45 minutes, sir. Sorry for just dragging you so long. Thank you very, very much. Thank you to all the participants and MCure as our professional partner. Guys, our next meeting will be again the last Tuesday of next month, which is on 24th September. And we'll again meet with some part of transplant immunology. Thank you very much, Dr. Vikram, once again. Thank you, guys. Have a great night. Thank you.
for
Good night.
inviting me.
Thank you,
Thank you,
sir.
sir. Good night.
Thank you.
Good night.
Good night.